The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss late treatment effects in survivorship. My name is Ambreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker today. Dr. Patrick Wen is Professor of Neurology at Harvard Medical School and Director of the Center for Neuro-Oncology at Dana-Farber Brigham and Women's Cancer Center. He was the president of the Society for Neuro-Oncology from 2017 to 2019. He was formerly the editor-in-chief of Neuro-Oncology and currently SNO executive editor of Neuro-Oncology. He is also a steering committee member of the Response Assessment in Neuro-Oncology Working Group. His research interest is in novel therapeutics for brain tumors, as well as novel clinical trial designs and response assessment and endpoints in clinical trials. Thank you for joining us, Dr. Wen. You may now begin your presentation.
Thanks so much, Ambreen. It's a real pleasure and honor for me to be here to talk about late treatment effects in survivorship. These are my disclosures. None of them are directly applicable to what I'm going to talk on. So as we all know, treatments have a range of side effects, and some of them are more common than others. Many of these side effects occur with time, and although there are some side effects immediately when you receive the treatment, these side effects tend to worsen over years. So I'm going to focus on these particular late side effects. Some of them are from surgery, from radiation therapy, the effects of chemotherapy. Many patients remain on a variety of medications that can cause side effects, and these can lead to a variety of issues, including cognitive problems, psychological and emotional issues. And then at the end, I'll touch on some recommendations related to activity, exercise, and diet. Just before I begin, in terms of definition, the Office of Cancer Survivorship at the National Cancer Institute and other organizations indicates that survivorship starts at the time of diagnosis and lasts throughout the lifespan. And included in the definition of survivors are family members, friends, and caregivers. The main reason for including these people is that most cases, cancer is not experienced alone, and caregivers are the unsung heroes, providing physical and emotional support to the cancer survivor. As this graph shows, the number of cancer survivors is increasing significantly. And while this is a graph for all cancer survivors, the same is true for brain tumor survivors. Sorry, having some trouble with my... So the goal in treating brain tumors is to cure patients of these tumors. And currently, the mainstay of treatment is radiation therapy. There are now advanced techniques such as intensity modulated radiation therapy and proton therapy, and also chemotherapy. In addition, there are now novel therapies that are being evaluated, targeted molecular therapies that have made significant progress in treating other cancers such as melanoma are also being studied in brain tumors. And in small subsets of glioblastoma patients, such as those with the BRAF V600E mutation, the use of targeted therapies can produce responses such as this that can be durable. In addition, as many of you know, there's a lot of interest in immunotherapies, both with vaccines and drugs that stimulate the immune system, as well as oncolytic viruses that can grow through the tumor and kill tumor cells, but also induce an inflammatory response that can hopefully have an anti-tumor effect. This is a patient treated with a herpes virus that my colleague Nino Chioka developed. And you can see here that after one injection, this patient had a response that was quite durable. In terms of survivorship issues in patients with brain tumors, I think continued surveillance with imaging studies such as MRI to detect recurrence is of course important. But there are many other issues that are important related to the long-term and late effects of the treatment of brain tumors. These include a number of issues, including fatigue, cognitive and psychologic issues, trouble with sleep, sexual dysfunction, pain, infertility, bone loss, metabolic syndrome, and problems with blood counts in the bone marrow. Most patients with brain tumors start off with surgery. The goal of surgery is to take away as much of the tumor as possible to relieve mass effect, to provide tissue for histologic and molecular diagnosis, and hopefully to improve the duration of their lives. For glioblastoma patients, you have to take out at least 80% of the tumor to have any impact on the long-term outcome of the patient. And usually you have to do a gross total resection, such as that shown here on this slide, to have a significant impact on the patient's survival. Surgeons nowadays have a variety of techniques that improve the safety of surgery. They have intraoperative MRI where they can image the tumor during surgery to see how much is left. They can do functional imaging to look at the important areas of the brain, such as speech and motor areas in relation to the tumor. They can do intraoperative mapping to determine where the important areas are. Or they can do tractography to look at the white matter tracts. More recently, there have also been techniques such as 5-aminolevulinic acid. This is a dye that the patient drinks, and then under fluorescent light, the tumor shows up as this pink that can be removed. And this type of approach is now FDA approved in the US and allows the surgeon to potentially do a more extensive resection. However, in doing surgery, you have to balance the attempt to take out as much tumor as possible to improve the survival of the patient with producing deficits. The deficits can improve with time, but can lead to long-term disability. And there are a number of studies that shows that patients who have deficits from surgery do not have the significant benefit in terms of long-term outcome. Perhaps the most important treatment for brain tumor patients is radiation therapy. With conventional radiation therapy, the tumor plus a 1 to 2 centimeter margin is radiated. And as a result, a lot of the surrounding brain is exposed to radiation. Nowadays, most people get intensity modulated radiation therapy. Here, the beams can be shaped better. So some areas will receive a higher dose and other areas will receive a lower dose. This results in more accurate delivery of the radiation therapy and less exposure of normal brain. After radiation therapy, months or years later, there can be long-term effects. Usually the white matter is affected more than the gray matter. And the mechanisms are not entirely worked out, but three main things happen. The blood vessels in the radiation field gets damaged, so the patient can be at risk of strokes. There's damage to the glial cells, the supporting cells in the brain that produce the insulation of the nerves. And if this is damaged, the insulation of the nerves gets damaged in a process called demyelination. And then there's injury to the neural stem cells that gives rise to the neurons in the brain. This slide shows the location of the neural stem cells. And perhaps most important are the neurostem cells in the hippocampus in the temporal lobe that's important for memory. In a number of studies many years ago now, Michel Mongi showed in animal studies that after radiation, there is increase in these activated microglia, these inflammatory cells. And these inflammatory cells damage the neural stem cells and in turn reduce the number of neurons that are made. And this contributes to the cognitive problems after radiation therapy. There is also damage to the white matter tracts in the brain. This is in a patient who had whole brain radiation. And you see this scarring in the white matter on both sides of the brain. And here you see a patient with a glioblastoma who had radiation to this area surrounding the tumor. And you can see the changes in the white matter tracts. Less commonly, a number of years after patients receive radiation therapy, they can get radiation necrosis, where there's actual death of the tissue in that area. This is a young man who had radiation to a tumor that's like a meningioma, and then 19 months later developed mental status changes, and this enhancing area that can mimic a tumor that turned out to be radiation necrosis or damaged tissue on a biopsy. Separating necrosis from tumor coming back can be very difficult. Sometimes a PET scan is useful. Here, a PET scan shows that this area takes up the PET tracer, suggesting this is tumor, whereas this area on the side here does not take up the tracer, and this was radiation effect. Nowadays, we can also do special MRI scans, including perfusion MRI, where they use software to look at the rate at which the contrast is injected into the tumor. And in areas of radiation damage, there isn't increased blood flow, but in areas of tumor, there is increased blood flow. So that's a test that many of you may have had called perfusion MRI, and that can be useful also. The likelihood of developing late radiation effects depends on many things, including the radiation dose, the size of each dose that's delivered, the volume that's treated. It also depends on the age of the patient. So infants, for instance, are very vulnerable to radiation therapy. And these young children, significant efforts are made to try to avoid radiation therapy until they get old enough. And then radiation therapy also has increased risk in the elderly population. Another group that can have increased side effects from radiation are those with other medical problems, such as high blood pressure, diabetes, and atherosclerosis. And then some chemotherapies, such as methotrexate, which is used for primary CNS lymphoma, are also associated with increased effects. If radiation necrosis develops, there are a number of treatments that are available. There's often a lot of swelling, so steroids can be used. If the necrosis is bad and produces a lot of symptoms that the steroids cannot control, you can try and remove the tissue with surgery. And nowadays, there's also laser therapy that can be used to burn the necrotic tissue. One medicine that is now used with increasing frequency is a medicine called bevacizumab or Avastin. This is a drug that reduces swelling very well, better than steroids. Sometimes people are treated with hyperbaric oxygen, but the evidence for this is not very strong. These are scans of patients with necrosis and swelling, which you can see as white on these scans. And then after treatment with Avastin, you can see that the swelling is significantly improved. And so the Avastin is used quite commonly to treat the swelling from this condition. I mentioned earlier that patients who get whole brain radiation can have diffuse white matter changes that are associated with cognitive problems. And over time, the brain can actually lose nerve cells or neurons and can actually shrink or atrophy. Here's a side view of a brain, and this is the ventricle, the fluid-filled space in the middle. This is about 3 times the size it should be. And here you can see shrinkage of the brain. So cognitive issues after radiation therapy is a significant problem. And it's something that there's a lot of research going on to try to avoid. These cognitive issues can affect the ability of the patient to return to work, can affect their independence, their relationships, the ability to enjoy leisure activity, and the fear of future cognitive decline can affect the quality of life. There are a number of cognitive issues that can occur. Perhaps the most prominent one is memory. It's really short-term memory that's affected. It's what you did recently or what you had for breakfast. So people will often say the memory's not so bad, they can remember things that happened many years ago. But that's usually not the type of memory that's affected. It's a short-term memory that's affected. Other things that can be affected include attention and concentration, something called executive function that I'll go into a little bit more in a moment, and the speed of processing of thought that can also be slowed down. Executive function affects our ability to organize, and it affects regulation, our ability to take stock of the environment and change behavior in response to it. So executive function helps us to manage time, to pay attention, to change focus, to plan and organize and remember details. It helps us to avoid saying or doing the wrong thing. And it helps us to do things based on experience and to multitask. And all of these can be affected depending on the location of the tumor and the treatment. There are some specific syndromes that are recognized. So the frontal lobe, where most tumors are located, can be divided into different parts. So the base at the front of the temporal lobe can lead to a disinhibited syndrome, where people can feel agitated, there can be behavioral problems and emotional lability. The mesial frontal lobe, this is in the middle of the frontal lobe near the midline. If this is affected, then there's a psychomotor slowness and apathy. It's almost like they're very depressed and they're not doing anything. It takes them a very long time to do anything. And then on the outer side, in the dorsolateral area, this area can affect executive function. Patients can perseverate, they keep doing the same thing over and over again. And there's also psychomotor slowing. And then if the sides of the brain, the temporal lobes are involved, this is where the hippocampus is located, where memory is located. And so patients with treatment here can have trouble with memory, especially short-term memory. And this is an area where there's an increased risk of seizures also. These cognitive issues don't occur only with time. They can be present at diagnosis because of the mass effect of the tumor itself and because the tumor secretes chemicals that can affect cognitive function. The therapies that I mentioned, including treatment procedures, can exacerbate these cognitive issues. Some patients have never had radiation therapy and only received chemotherapy. such as those with breast cancer. But certain types of chemotherapy can affect cognitive function and lead to a condition called chemobrain. The chemotherapies used for brain tumors, however, are much less likely to do this. It's not clear why some people are affected more than others. There may be genetic predisposition. But I mentioned earlier, those patients with diabetes, hypertension, high cholesterol are probably more prone because their blood vessels are affected by atherosclerosis. And then there are other things that can worsen cognitive function. So if you're tired or feeling anxious or feeling depressed, if you're lacking sleep, all of these things can make whatever underlying cognitive function you have feel worse. And these cognitive issues are a very important consequence of therapy. So to try to prevent these problems, there's been a lot of work on trying to make radiation therapy more accurate. As I mentioned, the IMRT, which is what most people have nowadays, is probably the technique that's most accurate, that is available to most patients. And this concentrates the dose in the tumor area, and the surrounding brain gets relatively less dose. There are more sophisticated techniques, including intensity modulated proton therapies, that are available at some centers. These are not widely available and tend to be restricted to children and for some specific tumors. But as you can see, because this technique is more accurate, the surrounding brain gets relatively little radiation therapy. With brain metastases, because the metastases can be widespread throughout the brain, the standard treatment is usually whole brain radiation, and as a result, there can be significant cognitive problems. Because of this, there's been increasing emphasis on what's called stereotactic radiotherapy, where beams are administered in different directions and they concentrate on the tumor area, killing the tumor cell, but sparing the surrounding brain. And so increasingly, stereotactic radiosurgery is being used to treat brain metastases. But sometimes even when you have this radiosurgery technique available, there are just too many metastases to treat this way, and you still have to give whole brain radiation. One approach that is now becoming used more frequently is whole brain radiation with hippocampal avoidance. So these are the hippocampi where the memory resides in the brain. And the idea is you give a high dose of radiation to most of the brain, but where the memory areas are, you try to reduce the dose. And using this technique, it reduces the cognitive problems slightly. So this shows with time the number of patients with cognitive problems. And this is with whole brain radiation. And with the hippocampal avoidance, there is some reduction in cognitive problems, although many patients still experience it. So this is becoming more common. So when patients have cognitive problems, in terms of the treatment, it's important to address fatigue, lack of sleep, depression, and anxiety. Low thyroid function can contribute to cognitive problems. You can see here in this diagram that the pituitary gland, it's just under the brain and is often affected by radiation, and over time can be underactive. And this can lead to reduced production of thyroid hormone that can exacerbate cognitive problems. And that's an easy fix because you can just replace thyroid hormone in the form of a pill. Other things that can help are mindfulness-based stress reduction programs, exercise. Ideally, we would have some technique to help the neurostem cells regenerate so that we can have more neurons from memory. Unfortunately, right now, there's nothing we know that can increase neurostem cells, with the exception in animal studies of exercise. So that's something that I think for many reasons would be good for patients with brain tumors to undergo. Exercise might help memory, we don't know for sure, but it helps other things, including fatigue and long-term outcome. If the cognitive problems are problematic, you can do neuropsychologic testing and cognitive therapy. There are online apps such as Lumosity, Brain HQ, and others. And then there are medications that are being tried. The one that might have some benefit is a medicine called memantine or Namenda, which is used for Alzheimer's disease. Other medications have been evaluated, have been less helpful. So as I mentioned, the one medicine that might be useful is memantine. Memantine affects some neurotransmitters called glutamate. And in a study, patients with brain metastases who received whole brain radiation, half the patients just received standard whole brain radiation. The other half received this drug at the start of radiation and for 6 months afterwards. And what they found was that the patients who received memantine had less cognitive problems than those who just received whole brain radiation alone. This is a very easy medicine with relatively few side effects. And so it's something that our radiation oncologists often prescribe to patients who are receiving whole brain radiation. We don't know if this medicine has the same benefit in patients with gliomas and other brain tumors receiving radiation therapy. But since it's well tolerated, we sometimes use it. There are a whole host of other medicines that have been evaluated to try to reduce the consequences of cognitive problems in brain tumor patients. Drugs like modafinil, methylphenidate, donepezil. These unfortunately have not been very helpful. Before I finish talking about radiation therapy, I just want to mention some indirect effects. The radiation can have effects on blood vessels. It can induce second tumors. It can affect endocrine function. So radiation can affect both large and small blood vessels. And here you see someone who had radiation to the carotid arteries that feed supply the main blood supply to the brain. And you can see this narrowing here. This is a patient I looked after who had radiation to a brain tumor and did really well from the point of view of the brain tumor, but many years later had a small stroke here. That is likely to be the consequence of the effects of the radiation on blood vessels. And then in patients who've had whole brain radiation, this is someone I look after who had a medulloblastoma that she's cured from. But many years later, she has these small cavernous angiomas. These are small collections of abnormal blood vessels that develop over time. Fortunately, the likelihood of these bleeding is pretty low. Another effect of radiation therapy is to induce radiation tumors. The most common are meningiomas in the covering of the brain, but it can cause schwannomas or nerve tumors or gliomas. This is a patient I looked after who had radiation many years ago and had this meningioma in a very difficult place. This is someone who had radiation for childhood leukemia and was cured of the leukemia, but the radiation caused a glioblastoma many years later. And this is someone that I looked after who had radiation as a child for medulloblastoma, from which he was cured. But 21 years later, he developed a glioblastoma. This was treated with radiation therapy and Temodar. And amazingly, he's been doing fine. He has not had a recurrence, and he works full time, is married with 2 children, And I saw him just a few months ago, and he's doing great. So I think in anyone who's had radiation a long time ago, it's important to follow them to make sure that there are no secondary tumors that require treatment. And then, as I mentioned earlier, the pituitary gland can also get radiated. And so hormones can be affected. Thyroid hormone most commonly, but hormones affecting sexual function can also be affected, and this can be a cause of low testosterone, for instance, which can be replaced. I'm going to switch and just talk very briefly about chemotherapy side effects. As you know, chemotherapy often can affect the bone marrow and lead to low blood counts. Very, very rarely. This can be very serious. The bone marrow can shut off and not make any more blood cells, or it can transform to leukemia. And while this is very uncommon, it's one of the reasons that periodically blood counts are checked in anyone who's had chemotherapy. Some chemotherapies like methotrexate can cause cognitive problems. And chemotherapy can also cause long-term problems with fatigue and fertility. Other medications can cause side effects. Seizure medicines frequently produce fatigue, cognitive problems, and if possible, you should talk to your doctors about coming off the medication if it's safe to do so. And then steroids, which are sometimes used in tumors in eloquent areas where they cause swelling, can have a whole range of side effects, including making the muscles in the legs weaker, causing problems with climbing stairs or getting out of a chair, as well as many of these other problems listed here. One long-term consequence of being on steroids is osteoporosis. This is someone I saw a year into her treatment who had these compression fractures, which were very painful. And so if you're on steroids long-term, it's important to take calcium and vitamin D supplements and work with your physicians to make sure that you don't have significant osteoporosis. There are also important psychologic and emotional issues. It's not uncommon to feel depressed or anxious, have post-traumatic stress disorder, and there are other issues that have to be considered. And with anyone who have these issues, it's important to seek referral to either a social worker or a psychologist for counseling. Sometimes seeing a psychiatrist for medications may be helpful. And there are mindfulness programs such as Headspace, and exercise and yoga can be helpful. This reference goes into this in more detail, and you can refer to this if you want more information. Another important issue is fatigue. This is very common, not only during the treatment with radiation and chemotherapy, but even afterwards. And this can have important psychosocial and economic impact. There are many causes. Of course, the therapy itself and the tumor itself can do it. The medications, especially seizure medicines, can do it. Not having enough sleep, feeling depressed, and then the emotional distress, deconditioning, poor appetite, and pain can all contribute to the feeling of fatigue. This lists some of the contributing factors in more detail. In terms of what you can do for the fatigue, as I mentioned earlier, you can try to optimize the medicines. So use the lowest dose of seizure medicine possible and try to come off it if it's safe to do so. If there's pain, to treat it appropriately. If there's depression, to address it with counseling and with medication. Sleep is often disrupted, especially in patients who are receiving steroids. And sometimes because of steroids and because of lack of activity, patients can develop sleep apnea. And this can also affect sleep and lead to tiredness subsequent the next day. Low thyroid can do it. Cognitive behavioral therapy can be useful, and exercise, physical activity, possibly yoga, can be useful. The data for acupuncture is less clear. 2 out of 7 studies suggested a benefit. And there is really no good evidence for other complementary therapies. And unfortunately, there's also little benefit from stimulants or medications such as modafinil or armodafinil. Another area that can be important is the effect of treatment on fertility and sexual function. And it's important to discuss this with your doctors. And if you're thinking of having a family, to consult a reproductive endocrinologist before starting on therapies, especially chemotherapy. Trouble sleeping is an important problem also. This can be addressed partly by having good sleep hygiene, trying to sleep at the same time, trying to not to look at your phone or iPads or TV right before you go to sleep. Being more active can be helpful. Medications such as melatonin can be useful as they're not addictive. Sleep medications can be used if necessary, but some of them can be addictive. And sometimes cognitive behavioral therapy can be useful. Another thing that's important is diet. So the National Comprehensive Cancer Network suggests limiting red meat and processed meat, limiting sugar and processed foods, trying to eat a diet that's at least 50% plant-based, with the majority of the food being vegetable, fruits, and whole grain. Try to make sure your calorie intake is tracked. And if you want to drink, you can drink, but try not to drink to excess. And this is the recommended sources of dietary intake. There are studies that look at blood sugar levels and outcome in glioblastoma. And those patients with the highest blood sugar, here in yellow, unfortunately tend to do the worst. So it's important to try to have a good diet and work with your physicians with the use of medications to avoid becoming diabetic. And this can be a problem when you're on steroids because that predisposes to diabetes. And then the final thing I want to touch on is exercise. So the NCCN guidelines suggest ideally in a week, you should have 150 minutes of moderate intensity activity. That's defined as activity where you can talk but not sing, or 75 minutes of rigorous activity. You can say a few words without stopping to catch your breath. And then ideally, you would have 3 sessions a week of strength resistance training. When you're undergoing treatment and feeling really tired, it's hard to do 150 minutes of exercise. But even if you try to walk 10 minutes a day initially and then gradually build up your exercise, that would be a good thing. And then just in terms of your daily life, try to make yourself more active. So for instance, take the stairs instead of the elevators. And if you park further away from the entrance, so you have to walk more. All these things help a little bit. And then avoid sedentary behavior, such as sitting for prolonged periods. This is just a list of some of the things you can do for moderate activity and for rigorous activity. For brain tumor patients, being active is really important, not just for your stamina, for your energy level, for your general sense of well-being. It's also important because we worry a lot about clots, especially in patients with glioblastoma. And so being active will also reduce the risk of forming blood clots in the legs. And then there's a study that suggests that patients with high-grade gliomas, if they exercise, they just generally do better and they live longer. We're not sure why this is the case, but there are many other studies in other cancers that suggest that those who exercise more live longer. And so if it's at all possible, it would be important to increase your activity level. So I think in the last few years, the treatment for brain tumors is improving, and the goal eventually is to cure everybody. But we have to take into account also the effects, the long-term side effects, and to monitor closely for them and to try to treat them appropriately. So thank you so much. Be happy to answer questions.
Thank you so much, Dr. Wen. We will now be taking questions. If you do have a question that you'd like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen, and we'll answer questions as time allows. So Dr. Wen, one of the first questions that we have is for many long-term survivors, to others on the outside, they can look quote unquote normal, and it might be hard for others to understand why they're still not feeling 100% themselves. Do you have any advice on what patients can do to educate their friends and families about what they're going through and what they're experiencing?
Yeah, this is a very common problem. I think being open with them and discussing it with them is important. And then I think doing whatever you can to help minimize those symptoms, getting enough sleep, changing your medicines, exercising. But I know it can be a source of frustration to patients to look well but not feel well.
Thank you. And are there any steps that patients can take to help prevent some of the onset of these effects before they even happen?
So I think with radiation therapy, depending on the tumor, there can be some discussion with the radiation oncologists about the radiation fields. I think increasingly that the techniques are improving, and so there's less exposure of the surrounding normal brain to radiation therapy. I mentioned a drug called memantine that's used sometimes for whole brain radiation. And occasionally, I know some radiation oncologists have used it in patients with gliomas. But I think apart from those things right now, there are not a lot of easy things to do because you can't limit the radiation too much, otherwise it reduces the effectiveness of the treatment.
Thank you, Dr. Wen. This next question is for those patients who might have had a brain tumor in childhood and are now aging into adulthood. Is it recommended that such patients undergo continued surveillance indefinitely in order to screen for new tumors as well as late complications such as stroke?
Yeah, I think it's important to work with your doctors to have some kind of surveillance MRI scans. It doesn't have to be very often, but because there is a risk of second tumors, especially meningiomas, you want to detect them early and then treat them if it's appropriate. The development of strokes and cavernous angiomas and other vascular problems can also occur, and so the surveillance will also help. It's really important also to work with your family doctor to make sure that your cholesterol, your blood pressure, your blood sugars are as normal as possible, because those increase the risk of atherosclerosis. And will also increase the risk of late effects from the radiation therapy.
Thank you so much for that. And can you share with us what factors are considered when performing surgery in order to minimize some of the adverse effects that you discussed earlier?
I think the critical thing in surgery is how close the tumor is to eloquent areas, your speech area, your motor area. And so surgeons nowadays have become very good. They can map out where these areas usually are before surgery. And I think there also needs to be a discussion between the patient and the surgeon as to how aggressive they want the surgeon to be. Ideally, you take out all the tumor that you can see, but if the cost is that it could produce significant deficits, then it negates any benefit from that aggressive surgery. Not only would you have long-term deficits that you have to live with, but it actually doesn't help you live longer. So finding that balance is important.
Thank you so much. Another question we have here is about the side effect involving changes in your memory or memory loss. Are effects like this permanent, or can these be reversed over time? And if so, what are some ways to manage this and to help recover issues in the memory caused by the location of the tumor or treatments that a patient has undergone?
Usually two things happen. During radiation and for some period afterwards, the cognitive function, including memory, gets worse. This is partly because of swelling from the radiation. So that deterioration improves with time. But then a second phenomenon occurs where there's damage to the neural stem cells and to the white matter. And so over time, over many years, there's a gradual decline in cognitive function. It's the same kind of problem that you get as you get older. It's accelerated. That is harder to fix, but trying to be as active as possible, trying to use your brain as much as possible, and sometimes cognitive behavioral therapy and there are online apps that may be helpful. Those are really the only things you can do right now. I think a really important research area is to find ways to help the brain recover from this damage.
Thank you for that advice. Another question we have here is for those caregivers that are supporting their patient, their loved one through the experience, and their loved one is experiencing, a lot of fatigue, and they don't have that motivation to exercise or to do what they need to help their well-being. Do you have any advice for the caregivers as they're trying to motivate and help their patient get through this?
It can be very difficult if you're feeling lousy from the treatment, you don't feel like exercising. And then sometimes the frontal lobes are affected. And so the motivation is affected by the tumor. I think in addition to just encouraging them to do as much as possible, there are sometimes exercise programs, and some centers have an exercise specialist that can help patients develop regimens. I think there are these Live Strong programs at YMCA and physical therapy. All these things can help a bit, but it's really important to try to do some exercise, even if you don't feel like it, even if it's only walking for a few minutes a day initially, because over time that will improve and you can do more and more, and hopefully get to the 150 minutes a week that's recommended.
Thank you so much. Now, can you talk a little bit about what the side effects might be, or how side effects might differ between taking Temodar as a pill versus having it intravenously? Are there differences in the late effects from Temodar depending on how it's taken?
No, the side effects, the immediate side effects and the long-term side effects are the same. The only reason for giving it through the veins is if you have trouble swallowing the pills.
Thank you so much for clarifying that. Are you aware of any late effects associated with using the Optune device?
No, not that I'm aware of. The main effect is, as you know, is you can get a rash under the electrodes, but I don't think there's any described long-term effects of Optune.
Thank you so much. And earlier in the presentation, you talked about whole brain radiation and how it's used for brain metastases. Are there any advances that you're aware of that can help provide more targeted therapies for those who do have a brain metastases so they don't have to deal with some of those late effects that you mentioned that can occur from whole brain radiation as opposed to targeted treatment?
So there are a number of things that I use nowadays to try to avoid whole brain radiation. I think nowadays whole brain radiation is the treatment of last resort. So the stereotactic radiosurgery that I mentioned, this is the focused radiation doses to each tumor, is used most of the time. And you can treat nowadays up to 10 tumors. Some people even treat up to 20 tumors with these focused doses of radiation. And that spares the surrounding brain to some extent. The hippocampal sparing treatment, where you give whole brain radiation, but you reduce the dose to the sides of the brain, the temporal lobes where memory is located, that also reduces the cognitive problems from whole brain radiation. And then the other area that's starting to receive a lot of attention is the use of targeted molecular therapies and immunotherapies. As you know, these treatments are starting to show a lot of benefit for many types of cancers, including lung cancer and melanoma and some other cancers. And so another approach is to try to use these treatments to treat small brain metastases and avoid having to give any radiation at all.
Thank you so much. Now, during this conversation, you had discussed changes in cognition as a potential late effect. Can you talk about any other medications, therapies, or even holistic methods that can help patients cope with changes in mood and cognition?
There's been a lot of work trying to find something that helps cognition. I think, unfortunately, with the exception of memantine or Namenda, which is used to help memory problems in people with Alzheimer's. Apart from that drug, all the other studies have not shown benefit from anything else, really, both medicines and supplements. So some of the other drugs like Aricept, which is commonly used for Alzheimer's, has really not been that helpful. So this is an area that needs a lot more work, but it's a really important area. And I think, unfortunately, for supplements, there's really nothing that definitely helps.
Thank you for that. Definitely sounds like it's an area of improvement, and we do hope that we continue to see advancements there. Do you have any tips for those patients and survivors who've experienced more debilitative side effects from their treatments that may have caused them to become nonverbal or immobile? What are ways that they can help take care of their well-being or maybe try to minimize those types of effects?
I think there are many causes of why someone becomes nonverbal. And of course, if the tumor is near the speech area, that can be a big problem, both in terms of understanding and producing speech output. But sometimes if the frontal lobes are affected, then the patient has reduced speech output and just appear more apathetic. And sometimes in those patients, medicines like Ritalin helps a little bit. But it's a very difficult thing because the communication is so disrupted and it makes taking care of them very difficult.
Thank you, Dr. Wen. Can you share with us how a patient can determine if the issues that they're now experiencing are late effects related to their brain tumor diagnosis and treatment, or if it's due to a new condition or some other underlying conditions?
I think this is something that your neuro-oncologist should be able to help you decide. The late effects are very well described, and so I think if the problems fall into that category, then it's likely to be late effects. But nonetheless, it's important to make sure that other things are not also happening. So this is something that you should work with your neuro-oncologist. And most of the time, it's not that difficult to differentiate those two types of problems.
Thank you so much. And what about those patients who might have had a benign tumor or a tumor that only required surgery? So they're not really having an ongoing touch point with a neuro-oncologist. Who is the right person for them to turn to if they're dealing with potential late effects or issues years after their surgery?
I think some of them are looked after by neurosurgeons or by their primary care physician, but they could be referred either to a neuro-oncologist or to what's called a behavioral neurologist. These are neurologists who specialize in cognitive issues, and they can be helpful. Even a meningioma, for instance, which is treated with surgery, it's not at all uncommon for these patients to have long-term sequelae, even though the tumor is gone and they're doing well from the point of view of the tumor. And so I think it's important to have these symptoms evaluated, because if there's anything we can fix, we want to fix to maximize the quality of life.
Thank you so much, Dr. Wen. I think we have time for just one more question. Do you or are you aware of how stem cells might be able to be used to combat some of these late effects, especially in cognitive stability and other areas? Is that something that's being used or explored at all?
I think that's the holy grail. I think right now you can't put in stem cells. I think there's a lot of research in trying to get the stem cells that are there to function better and to repopulate the neuronal population. So that's something I think hopefully will become a reality, because it's something that's important not just for patients with brain tumors, but as you can imagine, for strokes, with Lou Gehrig's disease and other problems as well. So there's a lot of research there, and hopefully that will translate into something that's tangible that we can use to help patients with brain tumors also. But right now, as I mentioned briefly, the only thing, at least in animals, that's been shown to help stem cells is exercise. And so apart from all the other benefits of exercise, that might be one theoretical benefit of exercise in stimulating the neurostem cells.
Great. Thank you once again, Dr. Wen. That is all the time that we have for today, but I just wanted to thank you all for joining us, and thank you again, Dr. Wen, for your wonderful webinar presentation. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, Email us at abtacares@abta.org or give us a call at our care line at 1-800-886-2282.